everybody. Leigh, Hale, Ingham, and it's my pleasure and honour to be the chair of this session 2, which is on injury and disability. We're going to move through quite quickly to try and make up some time. Unfortunately, we may not have as much time for questions and answers, but we'll do our best. So without any further ado, and remember that to use the question and answer session to ask your questions of our speakers. So moving quite quickly onwards, it's my great pleasure and honour to introduce 4 speakers for the next session. And so that's Dr. Tristram Ingham, Dr. Paula King, Bernadette Jones, and Gabrielle Baker, who all hail out of University of Otago, Wellington. And I'll leave it at that so we can save time. Can I hand over to you, Tristram, Bernadette, Paula, and Gabrielle?
Tēnā koutou katoa. Hi mihi mahana ki a koutou. Tuatahi, tēnei te mihi atu ki a koe Peter Jackson, mō tō karakia. Hoki ki a koe Professor Hale, mō tō api, mō tō karakia hoki. Ko waio, ko takiti mutu waka, ko ngā rororo te awa, ko ngā tika nunu ki Heratonga, te iwi ko Tristram Ingham aho. Nō reira, tēnā koutou, tēnā tātou katoa. I'll just like to introduce my fellow colleagues as well. I'll just hand to them in order, just so they can introduce themselves before we commence the kōrero. Bernadette.
Tēnā koutou katoa, ko Kuruhapo te waka, ko Ruapehu te manga, ko Wangahu te awa, ko Kawangaroa te marae, ko Bernadette Jones Takawingawa. Kia ora, Paula.
Ngā mihi nui ki a koutou katoa, ko Waitenei, ko Tutamoi te manga, ko Opanake te awa, ko ngā tokimata whaurua, ko Mahuhu ki te rangi, ko Tainui, ngā waka, ko Te Aupauri, ko Te Raroa, ko Ngāti Whatua, ko Ngā Puhi, ko Waikato Tainui, ko Ngāti Mania Poto, ngā iwi, ko Paula Toku King, taku ingoa. Nō reira, Gabrielle.
Kia ora koutou, ngā pui aho, Gabrielle Baker, tuku ingoa, and I'm associated with my colleagues here at Otago University Wellington, but I'm not myself there. I'm supporting them. Kia ora.
Kia ora. Well, today we've chosen to present a piece of work that we've been doing as a team. I think that often in health equity research, we can find ourselves very much pointing out what's wrong and struggling to have anyone listen. And really, I think we're using a navigation metaphor in this kōrero, and I think anyone that's been on a car journey with someone who you're pretty sure doesn't know the way, there are a number of steps that it takes to get that situation under control. First of all is actually having the person realize that they're lost. Secondly, convincing them that they may need to seek direction. And thirdly, then the wayfinding that occurs after that. I think the same is true in the health inequities research, where as inequities researchers, we find new and increasingly varied ways of pointing out that the system is lost. And we're using a metaphor of wayfinding, as I've said, but through the COVID, there has been perhaps an opportunity to recognise, for the state to recognise that it actually was lost. And that posed the next challenge, that how do we find our way? And so this presentation is about how we take the next step beyond just saying, yes, we are lost, to how do we find our way back on that path. I mean, I say that in a almost light-hearted way, but the inequities that occurred for Tāngata whaikaha Māori or Māori disabled community are unknowable because these inequities were not captured by the state, that there were no data collected that accurately and systematically capture this data. We know anecdotally there were a number of breaches of both the Human Rights Act, the Health and Disability Code. The impact may be unmeasurable, but if there is a silver lining to this, it is that recognition that I think the state has realized that there may be a need for change and for improved wayfinding in this area. So with that, I'll hand over to Bernadette. Kia ora.
Kia ora, thank you for that. For Tāngata whaikaha and Aotearoa New Zealand, disablement occurs secondary to being excluded by a society that takes no account of their culture, identity, or the meanings that Māori themselves give to disability. Māori have been disabled through deficit theorising and assimilatory practices that have marginalised and excluded Māori from their own knowledge base, language, cultural values, and practices. As Tristram had referred to, during the COVID situation, this brought out even worse situation. The COVID-19 emergency revealed a very real, ugly underbelly of New Zealand society through statements and acts of stigma and discrimination against people in terms of racism and ableism, undoing harmful societal norms and systematic negligence and marginalisation takes more than just being kind. Though that's a great starting point. Disabled people in New Zealand watched with sadness and at times horror at what was happening around the world. Stories of not for resuscitation orders for disabled people were shared, and allegations of eugenics at play as discussions took place about who would receive life-saving treatment. When disabled people face a lifetime of poor attitudes and barriers in which disability can be seen as a life not worth having, it is not surprising that many were scared and felt powerless, that the state might have to judge whose lives do and don't matter. It was a statement by Paula Tesoriero, the New Zealand Disability Rights Commissioner. So we're focusing on what can we do? We know the deficits are there and we're focusing on what can we do. We're proposing this practical and moral compass, which is informed by the work of Dr. Kamara Jones. And this is really a call for action that realises Tāngata whaikaha Māori rights as articulated under Te Tiriti or Waitangi and international human rights instruments. Comprises of 4 elements. The first, guaranteeing self-determination for Tāngata whaikaha Māori. The second, addressing all forms of racism, ableism, and other structural forms of oppression. The third, rectifying historical injustices, including those associated with colonisation and colonialism. And the fourth is allocating resources, in this case, particularly for the COVID-19 pandemic, but looking forward for the future, it's beyond, and it's got to be in alignment with the need.
The first part of the practical and moral compass is guaranteeing self-determination for Tāngata whaikaha. Now, I actually want to read out the quote on the screens, and this is being shared by Tāngata whaikaha Māori with us as part of our research that we've done. We need to go back to the way that Māori used to do it back in the old days, to re-indigenise the health system, not decolonise, but to re-indigenise it, only because Pākehā had all these years, 150 years plus of doing it their way, and it hasn't worked for our people. We've told them, we've done the research for you, name it. People have done all their research in Rangahau and have put it out there saying, what? It's not working for our people. How many more years do we have to keep saying your stuff is not working for our people before they finally give in and they go, oh, you're right. We're starting to see that. Oh yes, Māori are right, it doesn't work for their people. Can you just forward the slide, Bernadette, if that's okay? And I'll let you take.
Yeah, this one's up to me. So the second point in the compass is addressing all forms of racism, ableism, and other structural forms of oppression. And this requires governments and their agencies and health and disability providers to design, develop, and implement anti-racist and pro-equity policies. It has obligations on health professionals, including around cultural safety. And it requires a critique of the power structures that we take for granted. And I'm going to read out the quotes that we got from Tāngata whaikaha as well, but maybe not because it's just forwarded. Just want to go back, Bernadette, sorry. We live under a system that oppresses and suppresses us as people, as tangata whenua. If you look at the whole picture, it's terrible, and we get treated in that way. And we've got to live under their rules, their regulations, and their whatever, their tudes. Well, actually, the only time I become freaking disabled is when I'm accessing Pākehā services, or the environment.
Thanks, Bernadette. And the third component of the moral and practical compass is rectifying historical injustices, including those associated with colonisation and colonialism. So I'm just going to read out this quote. But I wonder if it is because do you think with our children that get taken away, do you think that this whole concept of disability for those that were born with it, and that was about taking us away, that they thought that we would be better off in institutions or with Pākehā families than with our own people. And I'm wondering if it was because as Māori, they didn't see that we were capable of looking after our own. So rectifying historical injustices, including those associated with colonisation and colonialism, involves, as our Māori colleagues, Professor Paparangi Reid, Associate Professor Dr. Donna Cormack and Dr. Sarah Jane Payne have highlighted, it's about the right to truth-telling about colonial history and its effects, the right to reconciliation and a process for setting right of past grievances, and the right to recognition of historical trauma and resources to heal. And this actually requires decision makers to understand the root causes of inequities for Māori and for tangata whaikaha specifically. Historical injustices that result in the marked inequities experienced by tangata whaikaha are evidence of breaches of te tiriti or waitangi. It also requires effective mechanisms for accountability and redress to ensure government agencies deliver on their obligations to tangata whaikaha. And for an example would be the ceasing of the detention and immediate decarceration of tangata whaikaha from state-run institutions that have perpetuated or enabled systematized violation of human rights, as well as criminal abuse of tangata whaikaha. And actually, you really have the opportunity to educate yourselves in terms of seeing what's happening with the Royal Commission and state abuse, and also Waitu 575 stage 2, the Hauora claims in terms of the disability stage and the Waitangi Tribunal. It's not as if the information isn't actually out there in terms of the knowledge that you would be able to source, to look at, to meet the requirements that we're talking about around historical injustices. Sorry, next slide, Bernadette.
And then you get me again. So the fourth point of the compass is around allocating resources for the COVID-19 pandemic and beyond in alignment with need. And again, a quote, they don't include us in a lot of their thinking, they don't. What upsets me is that it will have all these able-bodied people making decisions for those of us who are disabled, thinking that they know best. And this context, sorry, Bernadette, you've gone too fast for me again.
Yeah.
In this context, the kinds of things that in the article that we talk about are around ensuring high quality information for tangata whaikaha in a range of accessible formats, but it's also about taking immediate steps to like allocate those resources. So like PPE is something we talk about, and something that has happened since the article is also like the vaccination rollout. And talking about allocating resources in line with need, we're not merely referring to the proportion of current individual health or disability or welfare needs, but also to the structural needs of communities. So this includes things like maintenance of leadership, capacity and capability, collective voice, and mechanisms for effective engagement with and action by the New Zealand government. Now you can go next, Bernadette.
And we've talked about two critical prerequisites or foundational underpinnings of the practical moral compass for it to actually be able to be enacted. And that includes each agency who has responsibility for public services ensuring that policies, practices, and commission services are designed, implemented, and evaluated in genuine partnership with tangata whaikaha and their communities so that they will meet diverse aspirations and needs. And also, Gabrielle has touched on this, but high quality ethnicity data and disability data responsive to the epistemological aspirations and needs of tangata whaikaha, for instance, Matauranga Māori knowledges. And this involves Indigenous data sovereignty principles and tangata whaikaha governance and decision-making about the government use of data, and also rapid analysis, real-time modelling and dissemination of data via accessible modes and formats to inform, monitor and evaluate policies, programs and interventions that address impacts for tangata whaikaha. And I think, Tristram might touch on this and if we've got time for partai, but in terms of I think the COVID vaccination is a really good example of the absolute requirement to have rapid analysis, real-time modelling and dissemination of data for tangata whaikaha, and yet we don't actually know how many Māori with lived experience of disability have had access to vaccination. That's absolutely invisible, as Tristram touched on before, in terms of information being unknowable. It's the next slide, Bernadette. And we just wanted to actually finish on this quote from Associate Professor Dr. Donna Cormack, and because we think it's a very compelling and really kind of highlights all the issues that we're trying to reiterate, because we've been talking about this for basically, at least a year in the context of, say, COVID, but decades in the context of what tangata whaikaha have been fighting for. And some may find the idea of leaving decisions about access to care and potentially life or death situations to chance a somewhat arresting proposition. However, what should be alarming and prompt an immediate call to action is that our society is structured in such a way that for some people, a toss of a coin offers the best odds of a fair, equitable outcome. And I'm just wondering if Bernadette and Tristram or Gabrielle might have some reflections on that final slide as well.
Kia ora, Paula. I think sometimes the content of these kind of presentations can be quite depressing. We have seen a number of tools and systems be developed, including I think one that we referred to specifically was around an ICU triage tool that has the potential, if misused or even if misdesigned more specifically, to really penalise for a second time those populations that have been failed by the system the first time. Under the benign misintent of seeking the maximum good or the maximum number of people, the sort of strict utilitarian approach, and discriminating on the basis of what is perceived as lower life expectancy, the complications of comorbidity and other factors like that. We've seen it, the efforts to introduce such tools that are frankly discriminatory still exist, actually. I think there are, what we learned in, as I said in my opening remarks, is that we had the opportunity during the initial pandemic to really see an opportunity for a window of opening in the mentality that allowed for input. We were able to make some progress. We have been, during the lockdown, we were able to get real-time co-design with disabled people, Tāngata whaikaha. We were able to initiate a project that has the potential to, for the first time in New Zealand history, start collecting disability data.
Tristram, I'm sorry to be rude and interrupt, but we're going to have to call this session to an end.
Oh no, that's all right.
Timing.
I was on my last sentence. So,
Okay,
so there is hope, and I just want to say that it's now our opportunity to really, using tools like this or other mechanisms, really support the improved access and equity for our populations. Tēnā koutou katoa.
I'll introduce our next speaker, who's Katrina Bryant, who's a lecturer and associate dean Māori in our School of Physiotherapy. And Katrina, over to you.
Tēnā rā tātou katoa, ngā mihi nui kia koutou. I should probably open up my video now.
I think, Bernadette, could you stop sharing your screen so that Katrina can?
So thank you so much for this opportunity to present. I'm very humbled to be presenting today, and I've just been loving the kōrero that's been happening. And as I say, just incredibly humbled to be presenting alongside these very esteemed researchers in the space of equity. I'm just going to try and move it along. Ko waio, ko hoki kura te mauka, ko te tai o tākou te awa, ko Otago te marae. So I'm from Otago, and I'm an active member at the Otago Rūnaka. Born and bred in Dunedin, and I've been a physiotherapist for about 27 years, and had huge interests in bringing things Māori into the rehabilitation and physiotherapy space. I've been working at the School of Physiotherapy for about 13 years now, and supporting things Māori there. This year I've become the Associate Dean Māori and lecturer at the School of Physiotherapy. And I also own my own physiotherapy practice, so multiple hats. So the specific research that I'm going to be talking about today is actually Rūnaka driven research. So I also am employed by Te Rūnaka, Te Rūnanga o Otago to conduct this health research, Tauriti 2, which is addressing falls prevention, and actually it's just become a wellness practice for our kaumātua. So as I say, this research, I come with multiple hats, and this research is conducted directly out of Te Rūnanga o Otago, but it is in collaboration with the university. So this research was, the genesis of this research came from our upoko at Te Rūnaka, Edward Allison, who asked me, Katrina, what are we doing for our elderly and falls? And this was him when he was wearing his hat. He also wears multiple hats, and at this time he was also working at ACC as a Māori advisor as one of his hats. And so that sort of planted the seed I just want to go to, so what do we know about falls? It is a major cause of mortality in Aotearoa for our elderly. So it's one, we know that Māori have the same rates of falls, but they have higher impact following injury, and these are at inequitable rates, twice the risk for mortality. I'm just going to see if I can move myself out of there. And sorry, I'm just moving back. And we know that we can have an impact on falls. There's a lot of research showing that community-based exercise programs can have an impact. However, we have a very low rate of Māori that are participating in these effective falls programs. So, whoops, gosh, I'm flicking through. So there are many barriers for Māori accessing services. So I just want to sort of acknowledge the work that Tristram and everybody have been doing towards this. Everybody who's presented have been talking about barriers. Acknowledge we all know the barriers, and so I'm just we need to shift our gaze to looking at what are the barriers for our organisations to change their services based on this massive body of work, evidence that we know for the barriers. So that we need to shift the barriers of Māori to what are the barriers of organisations to implement and adapt their services based on that body of work. So anyway, the barriers that we know, mainstream programs on their own are not sufficient to address this inequity, and we know that there's enough evidence to show that Māori specific programs are suggested. So I don't want to focus too much, I'm just going to flick through, but we do know what the barriers are, and there are some very substantial evidences for solutions to this inequity space, which have all been presented this morning. Focusing on, my talk will talk about focusing on engaging with Māori health providers and iwi, hapu, whānau authorities to develop pilot models for Māori specific injury prevention. And that's exactly what our research is done. So my friend Terry Monga came to me with a research grant application. Somebody had given it to him and he said, you should fill this out. It was an HRC grant that was specific to Māori organisations conducting research. And so it came to mind Edward Ellison's tap on my shoulder to say, hey, this is some work that you need to do. So we did work collaboratively. So this was research that the Te Rūnanga applied for funding to conduct. And if it wasn't for our links and collaboration with the University of Otago, it would have been very difficult. So whilst that grant application was specific for Māori organisations, I have let HRC know the application itself was very tricky, and I would say did not focus so much on elements of Te Ao Māori, more on the academy and academic achievements. But thankfully, through our support from researchers at the university, we were successful in our grant application. So it's at this stage I want to acknowledge Donna Keane, who's at the Centre of Health and Activity and Rehabilitation Research Unit, CHAR, at the School of Physiotherapy. This is the only photo I can find of her, and this was taken of her working she's in the right there, working in the marae kitchen. But she was incredibly important and helpful in putting together the grant application in terms of all the processes that were required there. So that was with the support of Professor Leigh Hale, of course, the Dean of the Physio School, and then other collaborators. Gosh, if I'm sharing my screen, I'm cutting everybody out here. So let's see if I can move this down. Get me over there. Gosh, I'm not doing a good job of this. Maybe I'll move it across here, sorry. Anyway, yes, so Deborah Waters, of course, who's also sits, her office is in the School of Physiotherapy there, and she's one of the only researchers who has conducted falls research with Indigenous people. She's of course worked with the Zuni people in the States, so a world-renowned falls prevention researcher, along with Leigh as well. And of course, I want to acknowledge Jo Baxter in her support for this application and her advice around dissemination of our research. But there are a lot of other collaborators on board as well. We had, of course, Terry Monga, my friend, my other friend, Te Ao Mihia Rangihuna, who has worked in the health space and actually did facilitate some of the falls research, falls community services programs. And of course, I always want to acknowledge Margaret Dando, who has been very generous with her knowledge and work to develop the Steady As You Go program, which is an incredibly effective program in the community for falls prevention. However, she also identifies that Māori are just not accessing this program. And then also we had Māori movement practitioners, Jade Morgan and my sister Lou Katrina Bryant, who have done a lot of work in that Māori movement space, and Irihapiti Bull Moore, who is a kaumātua engagement specialist, who's also whakapapas to the Rūnaka. So we had a lot of people involved. We did wānaka. We met together. We talked. We talked about all of the evidence-based literature around effective falls prevention. We talked about Mātauraka Māori and brought all of our Mātauraka Māori into the space. We met with our kaumātua. We went to the Steady As You Go program. We went to Tai Chi programs delivered for falls prevention, and we pulled all these things together. Here's Moana Wesley performing some of her movements. Here's Jade Morgan. We further wānanga, many wānanga, and lots of food, testing our exercise program out with our community. So it was very community based. We were really relying solidly on our kaumātua for their buy-in and feedback. So really they are the centre of this whole process. We refer to them in Taureti too as our rōpū kairahi. They're the ones that guide us along the whole way, and this, they own it. They own this kaupapa. So they are the centre. So many wānanga that we had, and we finally came together with our Taureti 2 program ready to deliver. Here we are. We recorded some soundtracks to support the movement practice. This is Marae Styles recording, which was very effective, I will say. And we developed resources to support the movement practice, handouts, and also to support the research. So to support our research assistants, which we were upskilling. So we were building capacity within our Māori organisations and our Rūnaka. And also not just building, but also pulling together the skills that we have within our Rūnaka. We have Mirimuana Portaki, who is a qualitative researcher as well, who was on this project, and myself, who have done some qualitative research in the Hawamana Māori project. So here we are. There are many kaimahi and Māori within our community, which we've been able to pull into this research, which is fantastic, to inspire our communities to be involved in research, because research can be a dirty word in Te Ao Māori, when much of the research is just exposing our negative realities. It's good to be able to have some positive outcomes as well. So here we have our three, members of our three venues that we conducted this research. So we had kaumātua at Otago Rūnaka, Otago Marae, here at Te Kaika in town, and then out at Pokitaraki as well. So in all, we aimed for 30. We actually had 50 participants that engaged in our research, so that was fantastic. So it did require, as I say, upskilling and increasing, building on the skills of our community. So and showing a good template for effective research. So we used evidence-based measures to measure our physical improvements. And then also we utilised a model that also came out of our Hawamana Māori research, Te Pū, which is a model that we use to facilitate our discussion. So we did qualitative and quantitative research in this project. And so here we are with a lot of our exercises. We use the rāko, we use poi, we use our kumu or our tākaro, our games, meditative practices, posture, lots of things. And then we also had opportunities for our students to, here's out two of our physio students participating in the class and adding to some ideas. Whoops, next step. So we have an hour of exercise and then an hour of whakawhanaukataka. So this is really important. As I'm not an idiot, they don't just come for the exercise, but they do also come for the whakawhanaukataka. The social element is just as important in a wellness program. And this is where we also have our invited speakers. So we have here Lisa Cremo, who's also she's a Māori pharmacist also at the University of Otago, but we also have WINS come in. So invited speakers are invited based on the needs of the kaumātua as they identify who they want to speak to. We are very strong in making sure that whoever comes actually does the exercises with us. And they're also told not to present to the kaumātua, but rather answer their questions. Our kaumātua are sick of being told what to do. They've had a lifetime of it. And so it's really important that they feel like they can get their questions answered.
Sorry, Katrina, we're going to need to wrap up.
Okay, kapai. Our studying results were very exciting. This is two of our kaumātua after, no, this is a slide that we presented to them, but our findings were beneficial. And I feel terrible that I have to rush through this. So we did find that we had some statistically significant findings. But our main point was, to me, for us, was that it was an engaging program. So it was good for our Māori kaumātua. So there are lots of qualitative results that are important to hear. So that the voice of the kaumātua was the most important part. I'm just going to get through all of this. So there's lots of things that they said. Te Pūtahitanga acknowledged that it was good, so they funded it for another year. And here are our kaumātua, and they are presenting at the Te Pūtahitanga or Te Waipounamu conference. They're the best presenters of this kaupapa, because this is their kaupapa. So I guess I'm just going to flick right through where to the end of if there's any take-home messages. As you can see, there's a lot of people involved, and there's a lot of action involved. So this requires very good engagement. Any take-home messages that I can say is that for us to value community knowledge and capability, that might challenge our mainstream epistemological approaches. So rather than thinking, how can we get Māori onto our research, maybe just think, how can we get onto Māori-based research and support them with our skills that we have towards positive change. Kia ora koutou.
Kia ora topai, Katrina, for that really uplifting story. So thank you for that. I'm sorry, I am really conscious of time, so we're going to have to move on. And I'd like to introduce our next speaker, who's Dr. Meredith Perry, who's a senior lecturer with the University of Otago on their Wellington campus. So I hand over to you, Meredith.
Kia ora. I'm hoping that you can see my screen saying someone like anyone else.
Yes, we can see it.
Oh, great. Awesome. Thank you. So tēnā koutou katoa, ko Meredith toka ingoa. Thank you for having me today. And I'm really excited to be sharing this research with you. I obviously need to acknowledge some of my collaborators, Katrina, who you've just heard from, Bernadette and Tristram from slightly earlier, and Ali Calder, who is based in Christchurch. These colleagues have supported me and the two students whose work that I'm talking about today, Sarana and Julia Law. So for the purposes of this presentation, I'm going to be using the term disabled person, because it is a recognition of the barriers and discrimination that this large and diverse group of minority people in New Zealand experience. And I'll use the term Tāngata whaikaha Māori if I speak of Māori disabled people's health outcomes. So how large is this minority group? Well, in truth, we're not really very sure. The 2013 disability survey, which has not been repeated since, suggests that 25% of adults report having a disabling impairment. The Washington group set of questions that were used to determine prevalence at the last census found slightly lower rates, but this questionnaire has some issues, including not being validated for our New Zealand population. And why should this minority group be of interest? Well, because of their outcomes. 25% of disabled people have no school qualifications. Only 39% of disabled people are employed compared to 81% of the general population aged between 18 and 64. Recent statistics show that 23% of disabled adults do not have enough money to meet their everyday needs. They also have a 10-year lower life expectancy. And what about health outcomes? Well, the recent Health and Disability System Review found very high unmet health needs and inequitable health outcomes for disabled people. Disabled adults report higher levels of loneliness, poorer life satisfaction, and poorer mental well-being. Disabled people access health services twice as often as that of the general population, but they report multiple barriers to use. The increased use of the health service results in financial distress, and consequently 21% of disabled adults report not visiting their GP due to cost. That's in comparison to 12% of the rest of the general population. Barriers also include discrimination by health providers. And I just want us to hold on to that thought because we're going to come back to it. Overall, limited access, unsatisfactory experiences of healthcare increases the risk of secondary health conditions, and this further affects disabled people's health and well-being. And due to the ongoing systemic inequalities, the prevalence and impact of disability remains higher in Māori. Māori people have a higher prevalence of disability. 25% of Tāngata whaikaha Māori have insufficient household income to meet their daily needs, and 66% have an annual income of less than 30,000 New Zealand dollars. They specifically report issues with insufficient assessment, treatment, and access to culturally acceptable support, equipment, and care funding. So when we think about disparities or gaps, I believe that I personally, and as a health professional, have a moral and ethical obligation to ask why and to seek change. These avoidable, unfair, unjust structural inequalities in multiple domains actually create and maintain these health inequities for disabled people in New Zealand. And disability is a culture. It's subject to bias. Today, I will focus on institutional and interpersonal bias. This slide here talks about racism, but actually it's just as relevant for ableism, disableism. Implicit bias, part of interpersonal bias. This is the bias which actually occurs in people who consciously and genuinely believe in fairness, equity, and equality. But despite those stated beliefs, hold unconscious biases that lead them to react in ways that are at odds with their values. And this occurs because of priming. Everyday experiences in our communities, news coverage, advertising, other forms of media, so that we come to accept the unacceptable attitudes and behaviours as normal. Structural and implicit bias work dynamically to hold inequities in place. As I mentioned earlier, disabled people do report discrimination by health providers. This means that I, as a health provider, I'm part of the problem. We know from international research that health professionals fail to recognise disabled people as a distinct population with its own culture. They would do this for older people, children, ethnic minorities and other groups, but not for disabled people. Disabled people are twice as likely to report finding healthcare providers' skills are inadequate to meet their needs. They're 4 times more likely to report being treated badly, 3 times more likely to report being denied care. They report communication difficulties, lack of expertise on the needs of people with disability, derogatory attitudes, and overshadowing. In short, health professionals do not always provide equitable care to disabled people. So we must consider that substandard care of disabled people can evolve from a perceived lack of expertise, eventuating in health professionals having a preference of only working with non-disabled people or only certain types of disability. Educational institutions are one of the first places our healthcare workforce gains professional knowledge. Therefore, it's really appropriate to consider health professional students' knowledge and understanding about disability. So the first study I want to talk about was with Julia Law, who was a HRC Māori summer student recipient over 2019 and 2020. She conducted a cross-sectional survey to University of Otago health professional students. The survey comprised of several sections, including demographic data, professional education questions, knowledge of health, wellness, and disability concepts, attitudes towards people measured with the multidimensional attitude scale towards people with disabilities, and experiences of disability, including own impairments and time spent with disabled people. There are 122 participants. There were actually quite a range of health professional students involved. 77% identified as having a disability themselves. 53% of them knew someone who had a disability, but only 6% of them would regularly spend more than 20 hours a week with that person. And usually that person was a whānau or family member. 19% of them reported having training outside of the university on disability matters. And it's important to note that for this particular cohort of students, 43% of them had completed 2 or more years of undergraduate qualification when they completed this survey. So what did we find? Well, there was variable knowledge of health, wellness, and disability models. The responses were really interesting because it was an open question. They often would describe a model rather than the ability to name it. For instance, they would say words like, well, the house with the physical, spiritual, mental, and whānau components. We presumed they meant Te Whare Tapawhā. Often, though, there would be words like the Pacifica one. And for these instances, we were unable to map it to recognisable models. But as you can see, many students were able to name models or frameworks. There was actually an increased response rate when a drop-down menu of options was provided to students, and we particularly did this when we wanted to know about what students had been taught in their courses. Here, you can actually see now that some students noted disability-specific models and frameworks. When we asked about knowledge and models of frameworks for assessing needs, outcomes of disabled people in clinical practice, many of the students actually felt that they had no knowledge. Some of them felt that they had some knowledge, but really interestingly, the majority of the students did not answer this question, which we have to wonder about why they were not able to do so. If we move on to the results from the multidimensional attitude scale towards people with disabilities. Now, this scale has 3 dimensions: cognitive, emotional, and behavioural. And when the questionnaire is delivered, it provides a social scenario from which the students were asked to rate the likelihood of emotions regarding that scenario, their cognitions regarding interactions with people with disabilities, and lastly, behavioural intent or willingness or actual response to this scenario. And what you can see here is a middling response, because 1 is quite negative and 5 is positive. There was no statistically significant difference for MAS scores for variables of gender or discipline. So I'm going to move on to the second study now, and then I'm going to pull it all together. And this was Sardana's Bachelor of Physiotherapy Honours study. And she completed this predominantly during Alert Level 4 in 2020, hence the reference to Zoom. So for this study, she interviewed 9 students. Their cultural backgrounds were Māori, Samoan, New Zealand European, Thai, Chinese, Filipino, Indian, and Sri Lankan. Some of them were international students. The participants were studying medicine, physiotherapy, dental surgery, and pharmacy. 8 of the students were in their 4th or further years of training. 5 knew a disabled person, but none reported having a disability themselves. So this is the model Sardana created to help explain the findings. 3 main themes influenced the health professional students' understanding of disability: life experiences, professional education, and societal exposure. So participants' life experience and culturally diverse upbringing, which is illustrated here by the roots of the plant, created knowledge of how disabled people live or could live in society. And this was knowledge that came with the student to their professional programs. You can see here that they described thinking about disability in new ways from what they had from home. Some of them talked about that at home, disability was considered an act of God, which was like an ancestral thing passed down from one generation to another, or they talked about disability being taboo, with disabled people not looked at or spoken about, and that they were conditioned to this from a very young age. But there were also different understandings, with one participant mentioning that she felt disabled people were, or patients were, a negative connotation, and they would prefer to think about this group of people as Tāngata whai ora, people seeking health, a more positive aspect of thinking about it. Participants who had more experience of disabled people prior to their current studies had a deeper and more nuanced appreciation of the challenges disabled people face in accessing health services and obtaining equitable outcomes. So you can see here that this particular student talked about the fact that it's up to us, the health professionals, the health system, to make it work for disabled people. It was not disabled people's prerogative to have to fit in with us. So there were three key themes under professional education, talking about changing beliefs, thinking about theoretical exposure, and then experiential learning. So the education that they were receiving allowed a safe place for the students to participate, reflect, and gain insight into pre-existing beliefs. And you can see here that one talks about, well, it's changed and reframed my cultural beliefs. I wasn't really sure what disability was. And I think that this was really important for the students. When we asked them to think about the current theoretical knowledge, there was reasonable understanding and confidence with talking about cultural health beliefs that were relevant to the New Zealand context. And they talked about how they had to learn to connect with and recognise the different backgrounds of the people that they were working with. Some participants felt reasonably confident talking about disability models. They thought that their course had done pretty well with that, but others were less sure, suggesting that they might have to work it out for themselves and try and evolve society. Overall, there was limited understanding of the prevalence of disability. In other words, how many of their patients that they might see might also have a disability. And they were uncertain regarding the additional health needs this particular group might have. They particularly noticed a tension between knowledge acquisition and passing. They stated that there's just so much we have to learn. There's all these barriers for us, like grades. We have to finish up our degree. We're all just rushing so that we can pass and move on to the next year. Experiential learning was incredibly important. Vicarious learning experiences, clinical practice, simulation events all help students develop better communication skills, empathy, and understanding on policy and support for disabled people. They started to talk about, well, I actually feel that some people, it's really difficult for them to get the support that they need to live their daily lives. Interacting with disabled people helped them think about what might be needed for this group of people to navigate. It enabled critical thinking about policy and funding. And it helped them think about the inherent problems with an impairment-based funding model. But mostly participants discussed treating everyone equally with respect and delivering good service. Thinking about someone like anyone else, just because they're a disability, we just treat them just the same. Another really important aspect about this one was that for some people, there was a real dissonance between their cultural health beliefs from their home country and their own developing beliefs. They realized that reconciling these differences on their return to their home country would be challenging. For one participant, she discussed the stigma attached to mental health in her own culture and how that was now not coherent with her current understanding. She was not entirely sure what she would do when she went home and how she would address this. She said, I just have no idea how I'm going to approach it. So societal exposure here is portrayed as the surrounding plants and an environment from the sun. We're thinking here about macro level policies, environmental accessibility, and all of this influenced how the students thought about disability. So the infrastructure at the university exposed particularly international students to disabled people and helped to decrease stigma, particularly if their past experiences were at odds with New Zealand culture. They said, I think New Zealand as a country, they've got quite a good system for disabled people. Conversely, other students perceived lack of teachers, mentors, and fellow students with disability was notable during their studies. They said maybe the fact that disabled people aren't really in the mainstream, it makes them a bit of a pariah. They're excluded. These students also commented on physical and environmental barriers around the university, their clinical placements, and public places more generally. So if we take these two studies all together, what does it mean? Well, knowledge about health models and frameworks does seem to improve over time with more years at university. But there is a limited working knowledge of social determinants of health, the outcomes of disabled people, and prevalence of disability in New Zealand. International research has also shown that health professional students do have a limited understanding of disability concepts. The use of models or frameworks in theory, but particularly clinical practice, was undermined by the current workforce bias and the students' pressure to pass. The student attitudes are comparable to international literature, but are they good enough? Is middling good enough? We must recognise that students have come with their own perspectives. Some participants recognised that they had been exposed to more stigmatised perspective of disability and that their beliefs took time to evolve. They thought about equality and not equity. They talked about treating everyone equally. This approach is inadequate when a group faces such large health disparities or when intersectionality occurs. So how might we make progress? Well, I think it requires us all to mitigate our own biases and change structures. Self-reflection on life experiences and cultural values can help students uncover attitudes and beliefs that foster discrimination. Just as students reflect on racism, health students should reflect upon disablism. We do need to increase the quantity and quality of disability-related content in our curricula. Increasing education about disability matters has been shown to improve attitudes of health professionals toward disabled people. Experiential learning is essential. Disabled people need to be teachers and they need to be an integral part of clinical opportunities. We know from literature that learning from and with disabled people is associated with a greater change and positive attitude. We need to prepare international students for the cultural divide on returning home. And we need to improve diversity in the health professional workforce. There has been recognition that improving student diversity is important for changing our workforce. And I just want to talk about the two items in red just a little bit more. Here are some of the key resources for us to consider necessary in our curriculum. The principles of the United Nations Convention on the Rights of People with Disability and the Treaty of Waitangi form the basis of our New Zealand disability strategy. But also recognition of the health inequities faced by Māori and Pacific disabled people and the exclusion of Māori and Pacific worldviews has also led to the design and implementation of two additionally culturally specific disability strategies and action plans. These latter two documents encourage objectives such as self-determination, person and family-centered care, ordinary life outcomes, equity, enhancing cultural identity and relationship building. Arguably, they should occupy some aspect of our health curricula, and as the health disparities faced by disabled, Māori and Pacific people arise partly from the conflict of paradigms between Indigenous and mainstream systems. Finally, thinking about improving diversity at our training institutions. The students noted that there was an observable absence of disabled people from their teachers and in their class. Of course, not all impairments are observable, and many students may not disclose disability, as this can incite discrimination. But at the moment, there is limited data on disability inclusion in the health professional workforce, and the recent Health and Disability System Review recommended that we need more diverse people in our health professional workforce, including disabled health professionals. This means we must track change in this outcome. We must keep statistics on educational attainment and subsequent employment of disabled health professionals in the workforce. We all know that if you're not at the table, it is hard to have your voice heard.
Meredith, I'm going to have to
finishing.
stop there.
Just finishing. So I acknowledge the work by many in the university that has occurred in the past and continues to occur to advocate for disabled people's right. Thanks for listening, and I welcome your thoughts.
So thank you very much, everybody, for the session speakers. I'm sorry, we have run out of time for questions, and there are some questions in the question and answer box, especially one from Amber Coyle that perhaps people could address. And unfortunately, we're going to have to go straight into the break session. So I'm assuming we start the break and we finish it in about 5 minutes' time. So sorry, a very short break session. Thank you very much. And thank you very much for our speakers in this session. Thank you. Okay, bye everyone.